Concept here is not different from stroke. Keep in mind, this is the same brain, just a different type of injury. So in stroke, we discuss ischemic and hemorrhagic stroke. So in both cases, if it's ischemic caused by a blood clot, either stationary or a traveling clot, risk factors are similar. And for hemorrhagic stroke, there were 3 risk factors. We identified AVMs, aneurysms, and severe uncontrolled hypertension, and also sympathomimetic agents like cocaine or other stimulants that pretty much cause a sudden increase in blood pressure and then causes hemorrhage in the brain. So this one is just a different type of cause, but it's the same brain that is injured, this time not caused by a blood clot, not caused by a aneurysm or AVM. This one is caused by trauma. But same concept applies. We discussed extensively last week the concept of cerebral perfusion pressure. What was the formula again? MAP minus ICP. Okay, so that's CCP. So CPP equals MAP minus ICP. Okay, so unlike stroke, this one will have a more severe increase in intracranial pressure because the trauma is sudden. And again, the concept of, remember last week we talked about the 3 contents of the brain, and then we use the glass of water as an example. Okay, so that concept is called the Monroe-Kelly doctrine. Monroe-Kelly doctrine states that if volume, since there are only 3 things in the brain tissue 80%, 10% CSF, 10% blood volume, since it's already 100%, so the doctrine states if volume in any one of those components increases, then volume in another component must be displaced. You agree? Just like that glass of water. So if you add 1 more drop, it's already full. So something has to be displaced because you can't increase the skull volume or space over 100%. It's already filled. Okay. So this Monroe-Kelly doctrine only applies to a closed head injury, meaning someone who sustains a head injury with an intact skull. All right. This will not apply anymore if the skull is broken. So let's say Kurt rides a motorcycle and did not wear a helmet, splattered his brain all over the asphalt, over somebody's tires. Okay. So does it still apply? No, because his brain is all over the place. However, so we have John who wears a helmet. He still broke his skull, but at least all his brain tissue are inside the helmet. Okay, so we can still bury him intact. Okay, we don't have to scrape some brain off the cop's shoes, okay, and then put it back in him. So let's start with prevention. Now, head and spinal cord injuries are in this chapter. We'll discuss spinal cord injuries separately. The assumption is with any head trauma, we assume that there is also spinal cord injury and vice versa. Meaning if we have spinal cord injury, we also assume that there is head injury until we can rule it out with an MRI or a CAT scan. Are we clear? So until then, we assume both are present. Okay, because it makes sense. I mean, your head is sitting on the spine. So any injury to either can lead to the other. I won't read it for you. Please read the prevention recommendations on chart 63-1. Now, the problem in head injuries is the injury is not limited to whatever was sustained during the first 24 hours. Now, there are 2 sets of injuries here. We divide them into primary and secondary injuries. Now, what are primary injuries? These are the primary injuries. These are the direct result of the trauma, the penetrating or non-penetrating, meaning blunt force trauma sustained by the patient. These appear right at the moment of injury. However, the patient's problems are just beginning. The patient over the next 24 to 48 hours will develop up to 6 secondary injuries. So that's why you've probably seen in movies or maybe experienced this with a family member, wherein when you have a patient seen in the ER for a mild head injury, and then you wonder why were we sent home? Why was the patient not admitted? Because they did not meet inpatient criteria. You follow so far? Meaning the patient on admission did not show any secondary injuries. So therefore, let's say they were diagnosed with a concussion, which is a mild form of traumatic brain injury. So you suffered a concussion and then you'll be sent home. However, the discharge instructions will include manifestations that indicate one or more of the 6 secondary injuries that may develop. In which case, if the patient develops any of those new manifestations or worsening of the initial symptoms, then they will be instructed to bring the patient back, because did they suffer mild injury if those manifestations appear? No, that means they sustained moderate to severe now, meaning let me discuss the secondary injuries, okay, so that it will make more sense. Any question about the primary injury? So these are the physical injury to the brain caused either by the brain structures, like the skull, for instance, because can your brain bounce against the skull and sustain injury?
Yeah.
Yes, the skull is a hard surface. So if your brain bounces off, let's say we call that coup contra coup injury, meaning it ricochets. Okay, so let's say it hits here. Let's say you're a boxer. We have Stringer. So he was hit by Manny Pacquiao. Okay, right here. So the initial injury was in this side of the brain, but then will it ricochet over the other side? Yes, his brain will bounce off the opposite side and sustain, therefore, 2 injuries instead of 1. Okay, so we call that coup and then contra coup injury. So these are the initial or primary injuries. Now, what are those secondary injuries? So these are anything that evolves over the ensuing hours after the initial injury. So this can be any of the following. They can be intracranial hemorrhage, cerebral edema, intracranial hypertension, hyperemia, seizures, and vasospasm. Okay, there are a few more, but basically, what caused the secondary injuries? They are the effects from the following: from the hypotension, from the hyperthermia. So we discussed last week, what do we want the blood pressure to be after stroke? What is therefore the effect of hypotension? Meaning if this patient sustained a head injury, right? But then let's say they sustained other body injuries which caused them to lose blood. And now their blood pressure drops. So what is now the effect on CPP? It would drop CPP below 70. Yeah? Okay, so next one, hyperthermia. So we discussed last week, remember those several bullets that we discussed for interventions to manage increased ICP? So what is the effect of hyperthermia or fever again on CPP? Increases because increase or decrease? CPP. Or let me ask you, what is the effect of fever on ICP? Okay, so any increase in ICP will do what to the CPP? It will decrease CPP. Okay. Hypoxia, because when you have hypoxia, that means, is there hypercarbia? Yes, they always go together. Oxygen's low, CO2 will be high, and then vice versa, correct? Okay. Then infection, because infection, can this cause inflammation and swelling in the brain tissue? Can this therefore also trigger vasodilation from, let's say, fever or inflammation? Okay, so same thing. Electrolyte imbalances. So we have particularly what will happen to, let's say your sodium is low. What will happen to ICP? No, when you have hyponatremia, meaning imagine osmosis. So if your blood sodium is low, so where will water go? It will move from an area of lesser to greater. So there will be cerebral edema. Fluid from the blood vessels will enter the brain cells, causing cerebral edema, increasing ICP. And anemia. So what is the effect of anemia on blood flow and also oxygen flow to the brain? Okay. Okay, so there are so many here that can result in the secondary injuries, meaning these secondary injuries mentioned here will result from these effects from that initial brain injury. You follow so far? Any question? All right. So here's the Monroe-Kelly doctrine we just discussed earlier. So if you want more details, you can read that. But basically, I gave you the idea of, again, it states that if volume in one component increases, then there must be displacement of another component. Okay, so the injuries can range from scalp. Scalp injuries actually bleed a lot. If you've ever had a scalp injury, who among you here has had a scalp injury? I had one. I was cutting class. No, I went out of my school and then went to another school. So me and my friends went to a public school, and it was easy to get in there because there was this ditch, and all they had was barbed wires, and we can move the barbed wire and then get in. So I wasn't very experienced, so my dumbass got caught in the barbed wire, and there was just this one wire that hit me in the forehead. It didn't hurt much, so I just brushed it off. But then my friends told me, "Hey, they look pale, right?" And then they started sweating, looking at me. So what's wrong? I was covered in blood. It was just one small scalp injury, but then I was like, somebody hit me with an axe. Okay, so I went running home, and then of course my mom beat me up even some more. Yeah, I didn't realize until then that scalps are very, very vascular. They bleed a lot. Skull fractures, there are two types here. You can either have a displaced or non-displaced fracture, meaning open or closed. Let's go to manifestations now. So for head injuries, depending on whether or not there is a fracture of the skull, are the following. Some you can see, others cannot, meaning that you'll just see signs. If it's not obvious, then it will just be signs and symptoms of increased ICP, beginning with a headache, nausea, vomiting, mental status changes. Then there will be some pupillary changes as well. If there is an open skull fracture, so first signs will be leaking of the CSF from either blood or CSF from your nose, from your pharynx, ears, even in your eyeballs. Bruising over the back of your ear, right here, behind the ear. We call that the battle sign. This is basal skull fracture. And then others would be you have CSF leaking out of your nose or your ears. For any of these bleedings, we check for the presence of CSF because very rarely will it just appear as clear drainage. It's always mixed with blood. We cannot use a dextrose test because blood will have glucose, right? So it would make sense if you check a bloody drainage, of course it will be positive with blood. I mean with sugar, because blood has sugar. So the best way to check whether or not there is CSF is what is that test again? We do the halo sign. Okay, so you get a clean piece of dry gauze, dab the bloody drainage, and then observe for a yellow ring around the drainage on the gauze. If it appears, then that's a positive halo sign. There is CSF there. All right, let's go to management now. So management will depend on what type of injury was sustained. So we have mild, moderate, and severe brain injuries. So for our example, I mean, for our practical experience, this would be the only, well, I shouldn't say the only, but the best New York City hospital for brain injuries is Bellevue Hospital. So they're renowned worldwide for managing and rehabbing. They have an inpatient rehab facility on the 7th floor, I believe, for TBI patients. So if you're in that unit, you know, you're privileged. No other hospital in the country has the best experience to provide you. Okay, so they have an excellent traumatic brain injury unit and an even more excellent TBI rehab facility. I remember my rotation there. So we saw a patient 2 weeks before because it's like long-term care. Those patients stay there for a long time. So we saw a patient admitted from the surgical ICU to the TBI unit. When he was there, he could not even raise his head. I mean, this patient was a total transfer, right? So he was wearing a helmet for protection, and he couldn't hold his head up, couldn't do anything. He was a total feed, incontinent, etc. 2 weeks later, we saw the same patient. He was wheeling himself, in the wheelchair. He was feeding himself. He couldn't talk clearly yet, but he was speaking. He was communicating now, non-verbally as well as verbally, meaning he has a long way to go, but he is. I mean, 2 weeks. I would have never thought that he would ever recover. He was in the shape he was in. So it's a very good rehab center. So contusion is a form of mild brain injury. There are no manifestations. Okay, we'll go to a different section for the manifestations because you need to see what are expected, and therefore, if you see something unexpected, then those would be what you would report. Intracranial hemorrhage would be signs and symptoms would be those of increased ICP, so same as what we saw in stroke. Hematomas. Now, there are different types of hematomas here, developing in different layers of the meninges. So we have an epidural hematoma, we have a subdural hematoma, and then we have the intracerebral hematoma. Regardless of the location, though, if you look at this illustration, is a hematoma a space-occupying mass? Is it a space-occupying mass?
Yes.
Yes. So therefore, what do all hematomas do to intracranial pressure? They increase ICP. Moreover, so let me show you a normal ventricle of the brain. So let's compare these two figures. This is TBI. Okay, when you have a subdural, epidural, or intracranial hemorrhage or intracranial hematoma. This is a normal scan of the ventricles of the brain. See the location of the ventricles and the size of the ventricles? So ventricles, just like your ventricles of the heart. Okay, so these are cavities that store cerebrospinal fluid. So this is where the cerebrospinal fluid is stored, and they circulate all over the brain. What's the purpose of CSF? Why do we have them? For lubrication, for shock absorption. Okay, so this is the location, yeah? Look at what happens now if you have a hematoma. What happened to the ventricles? They are displaced, they're compressed. And what happened to the brain structures? Are they where they're supposed to be? Have they herniated? sideways, upward, downward, or a combination? Yes, there's a different combination here. So therefore, as brains herniate either sideways, upward, downward, what are they doing to the CSF circulation? They are blocking it, right? They're obstructing the flow of CSF. So therefore, if there's an imbalance now, because CSF production will not stop, therefore, CSF drainage must also be continuous, meaning it's constantly produced. Therefore, it must also constantly be drained in the skull. So if you have displacement here now, can it drain properly? So what condition will this result? If you now have an increased amount or volume of CSF in the brain, what do we call that condition? Hydro. John? Hydrocephalus. Okay. So can hydrocephalus occur as a secondary injury? Yes, that's one of the secondary injuries. And of course, that will cause increased ICP. Yeah. So I won't go into detail about the hematomas. Just know that, again, any hematoma, whether it's epidural, subdural, or intracranial hematoma, what do they all do to ICP? They will all increase ICP. Okay, so here's a concussion. So manifestations are here. So in mild TBI, which is called a concussion, again, mild TBI, the common term or layman term is a concussion. What are the manifestations? Here are the manifestations. So the patient will have a, no, these are now what you will report, but okay, didn't mention, okay, right here. So depends really on which part of the brain is affected. So patients with a concussion often complain of the following. So they'll have some bizarre, irrational behavior. There may or may not be any loss of consciousness, but the patient may have temporary amnesia or disorientation. Okay, those are the only manifestations. Maybe they'll have a mild headache or mild nausea. Those are also expected. However, like I said, do they meet inpatient criteria looking like this? No, they will be sent home, but with specific instructions. These are the instructions. They have to return to the ER when the following appear: decrease in level of consciousness, worsening headache. So again, I said there was a headache, right, in concussion, but if that headache gets worse, you bring them back. There's now dizziness. Patient has a seizure. Seizure again is a manifestation of increased ICP. Okay, so therefore there is now increased pressure. The patient will go into a seizure. Abnormal pupillary response, vomiting now, irritability, slurred speech, numbness or weakness of the arms. Because what are these symptoms now? Possibly a stroke. Okay. So if I put this on a test question, which ones will you report versus which ones are expected? If I put amnesia, expected. Disorientation, seizures. Okay. Alrighty. Okay, management. It won't be any different, like I said, for stroke, as far as management of intracranial pressure. So namely, what do we do with the temperature? What do we do with the temperature? Just monitor? Okay, we want the temperature to be normal. Okay, so treat fever. What do we want the oxygen to do? Normal or high? CO2? Normal, actually. Okay, we want it to be normal, not low. What about the blood pressure? Do we want a normal blood pressure here? Okay, this just the same as stroke. We want it to be Slightly elevated, 140/90 or better, just as long as it's under what? No, 185/110. Okay, don't forget, stroke, head injury, they're the same. What should the position of the head of the bed be? Okay, 30 degrees. Very good, children. And like I said, until we rule out spinal cord injury, during the initial intervention, patient must be in a rigid cervical collar. So among these secondary injuries again are cerebral edema, hypotension, respiratory depression. The respiratory depression here is the #1 indicator of brainstem herniation. Why again? Why is there respiratory depression and hypotension when you have brainstem herniation? Okay, because the brainstem is responsible for maintaining blood pressure, respiratory rate, and heart rate. So always monitor those. So this is not any different. The management again for as far as ICP caused by a stroke, ICP from head injury or traumatic brain injury, are they different? Exactly the same. Okay, so manage temperature, manage the head of the bed position, oxygenation, CO2. If needed, have you heard that we induce a coma? Have you seen? Okay, so if the patient does not respond to the measures already mentioned earlier, the patient will be given barbiturates. Patient will be placed into a barbiturate coma. The purpose of this is to decrease brain activity. Therefore, if you decrease brain activity, then there will be decreased brain oxygen demand as well, right? So it basically rests the brain until the swelling goes down. The patient will have a better prognosis that way. Okay, I mean that's a last resort though. We still have to do the we intubate the patient. We give mannitol, the diuretic, mannitol. Yeah. Okay. What was did I mention how to give mannitol? No, okay. So when you draw mannitol from the vial, it also comes in a glass vial. So when you draw it, the problem with mannitol is when you draw it, is it exposed to oxygen? Yes, because there's air displacement, yeah? So when you draw it, when it is exposed to the atmosphere, it forms crystals. So therefore, when you give it, it must be drawn with a filter needle to filter those microscopic crystals. Because otherwise, can they become emboli? Yes, those are solid crystals. So you need to use a filter needle. Are we clear? All right. You'll see it when you draw mannitol and you get a few drops in your fingers, and once it dries, you'll see not brown, white powder crystals on your cuticles. Okay, you'll see that. So that's proof that when it's exposed to air, to the atmosphere, it forms crystals. Supportive measures, this will be to address the secondary injuries. For instance, since they're at risk for seizures, what will be given to the patient? Yeah, specifically, what can we give? You finish seizures last semester. So what drugs are given for seizures? We can do that, but the choice actually is either phenytoin or levetiracetam, Keppra or Dilantin. But if the patient does have seizures, what will be given? Lorazepam or midazolam. Okay, you don't give both. So one or the other. Other sedatives, again, to induce a coma are propofol. Here's the reason. It has a very short half-life, so very ideal for these kinds of situations. When the patient has mild brain injury, mild to moderate, they have a decent prognosis. Any patient, though, that suffers severe traumatic brain injury, it would take a miracle to bring them back. So every severe head injury patient usually die within 48 hours on arrival if they make it to the hospital. Again, severe TBI patients who make it to the hospital die within 48 hours. You can bet your money there, right? So very few rare cases that they survive, but I've never seen one. I had a student before who he graduated, was about to take the NCLEX. It was September, October. He died in December. He suffered a car accident. And yeah, he was in the ICU for 48 hours and then he died. Textbook. We won't discuss or test this because this we really don't participate in the determining brain depth. We already did Glasgow Coma Scale scoring last week, so you're not allowed to bring a cheat sheet. You'll be scoring this by memory, okay? Yeah, on the exam and also on the quiz.
5, 6. 4, 5, 6. 5.
Okay, table 63-1, these are the manifestations by system. So neuro, respiratory. Why is respiratory and cardiovascular affected here again? It's a head injury. So why are there respiratory and cardiovascular, heart rate, respiratory? Why again? The brainstem. Because why is the brainstem beat up here? Again, whenever there is brain herniation, okay, it's the first one that will be displaced. Because why? Why is the brainstem always displaced? It's the only one closest to the exit. So it will be pushed out. And therefore, there will be respiratory and cardiovascular changes. Of course, there will be GI because if there is less blood flow now to the organs, will there still be any bowel sounds? What about kidneys? Will the kidneys also function well? I mean, your respiratory rate, heart rates drop. Okay, so they will all be affected. And of course, the musculoskeletal system, no brain function. Will your muscles be useful? No, useless. All right, and then remember these patients are bedbound. They cannot move. They're unconscious most of the time. So what are they at risk for? Skin breakdown, DVTs, and are they also at risk for peptic ulcers? Yes, and then Kurt mentioned PE as well. So after a DVT, may become a PE. That's about it for head injury. Any questions? Okay, let's go straight to spinal cord injury.